Okay, thanks for coming tonight. Appreciate you giving up your time. We've got 19 slides, I've counted them, so it's not going to take up too much of your time. We are recording tonight, so if you have any questions, we're going to save those to the end, and they won't be recorded if that's okay. All right. So we are going to talk about knee arthritis, and you will get older, but your pain may not necessarily get better. And there's some really good interventions that you can do to help yourselves. Okay, Joe.
All right, thank you very much. How do you write this? Just click it that way.
That's it. Yeah.
So what we're covering today is knee osteoarthritis. In this session, we'll be covering what is it, so actually understanding what osteoarthritis is, and then specifically for the knee. The evidence-based treatments. Honestly, there's a lot of stuff online that is not as reliable as I'd like it to be, not as trustworthy. So giving you a bit more detail in that sense, and then going through the short and long-term management from our perspective at Top Tier and how we can help you experience stuff like that. So thinking about the knee, specifically for osteoarthritis, why I bring this up? Because we're really caring about the three different parts, three main parts of the knee for knee osteoarthritis. Thinking the medial part, the middle part, the outside, lateral, and then behind the kneecap, patella. I think that's the areas we're worried about the cartilage and about them shock absorbers. Definitional wise, is degeneration of the joint cartilage and underlying bone. Very quite broad, to be honest with you, but with this X-ray image, we can actually see a knee with osteoarthritis. And we're thinking this part, so thinking the medial part, you can see how the bone is starting to grow, it's getting wider, and the joint space is getting narrower. Very, very common with knee osteoarthritis. A lot of the times it is bone to bone, but it doesn't always mean it's painful. So everyone experiences different levels of pain with knee osteoarthritis. But this is an image of what can happen because the cartilage is all smoothed off, and then this bone growth, osteophytes grow to give that narrowing and give the narrowing and give the widening of the actual knee itself. But why does it happen? That's probably why you're all here, to be honest with you. Why did it happen to me? Being alive is doing everything. Everyone has some form of osteoarthritis. It's nothing to be worried about, scared of. Doing day-to-day stuff, you would be defined as having osteoarthritis. For things we're more interested in a subjective point of view when we're having our consultations and going through stuff is the previous injuries. So if you've had any ligament damage or joint surface injuries, we tend to think more where the injury was. So if it was, again, them three parts, middle, the lateral and the medial side, and then thinking about what compartment they might experience later on in life for knee osteoarthritis. And then with considering the general health conditions, they're more predisposed to having knee osteoarthritis. And then inflammatory conditions. With inflammatory conditions, yes, it can link to knee osteoarthritis, but there's other arthritis that we have to consider when they've got inflammatory conditions as well as. That's all from me. So I'll pass you over to Keith.
Okay, thank you.
No worries.
So as Joe says, there is a lot of rubbish out there, and there's a lot of things that people do and try, and people spend lots of money on treatments that don't have great evidence. So we're going to go through the NICE guidelines, and that's the NICE are a group of clinicians that look at all of the available evidence, and they come up with sort of sensible treatment management ideas. And so really the core treatment for it is therapeutic exercise and weight management. And if you look through the NICE guidelines, which you don't have to because we have, but if you look through them, that phrase is repeated. So therapeutic exercise and weight management. So both of those are fundamental. And if you're coming for treatment with us, we would be thinking about whether weight management is necessary, isn't with everybody, and what type of therapeutic exercise you should be doing, along with information and support. So that's the overarching thing that the NICE guidelines talk about. The thing to be aware of is that doing exercise, so from the exercise part of it, the NICE guidelines do say that us clinicians should be warning people and educating people that when you first start, you may actually have a slight increase of symptoms. We don't want a big increase of pain because that causes pain inhibition and it sort of gets in the way. But to manage your osteoarthritis long term, you need to use your leg. You need to start using it and using the muscles. And when you start using something, sometimes you get a slight increase of pain. And it's something you have to just moderate and slowly work through. Okay, but it's playing the long term. So long term adherence. You got to play the long game with this stuff. All right, there's no quick fix for osteoarthritis. You need to play the long game. Okay. Weight management. Now, we are not dietitians. We have a very good working knowledge of weight management, and we can certainly advise people if it's a significant factor. And we do have to have those conversations with people, because if somebody is significantly overweight or obese and all we do is give them exercise, we're only going to get a small improvement. Whereas if they can manage the weight a little bit, reduce weight by a certain percentage, and it's not a huge amount, but a small change makes a big difference. So weight is now, it's a really big thing, but it's not an easy thing. I fully accept that. It's not easy, but it's really important. And the reason a small difference makes a huge change in terms of the pressure that goes on your knee. So when you're walking, is about 1.5 times your body weight goes through your knee. With stairs, it's 2 to 3. With squats, it's 4 to 5 times your body weight. So if you think of that, all right, if you lose 1 kilogram, then that's 5 kilograms less pressure on your knees as you're getting up from a chair. All right, so a small difference makes a big change. The other factor that we're not going to go into detail tonight, but the other factor is that increase of body fat has an effect on your metabolism, and you generally have more of sort of inflammatory markers within your system. So it's pure mechanics, but it's also the sort of the system, the chemicals that are in your body as well. Manual therapy. So according to NICE guidelines, manual therapy should only be considered if it's done as part of therapeutic exercise. Okay, so manual therapy is a good thing to do as for knee arthritis and hip arthritis, as long as it's done with the exercise part. Okay, if you're going somewhere and just paying to have your leg rubbed and moved around and you're not doing anything and you're not being given that wider support, it's probably not going to work. In fact, it won't work. But it's done as part of the package. It's a good idea. There is no evidence for acupuncture or electrotherapy. So all the various machines and things you can pay for, there's no robust evidence that helps. Equally with acupuncture, so that used to be on the NICE guidelines for knee osteoarthritis, so now it's not. So the evidence isn't strong enough to suggest that it's worthwhile. Now within this, you may have experienced or you may know somebody that's had some of these treatments and that individual has benefited. So when you look at this sort of advice, this is taking into account thousands of people and thousands of people's experience and overall what's the response. But within that group of 1,000 people, there will be some people that respond, but there's not enough to say it's an evidence-based treatment. Okay, so we don't offer those sorts of treatments. In terms of insoles, the insoles, orthotics you put in your shoes, knee braces, tape, splints, supports, those things can help, but only if there's joint instability or abnormal biomechanical loading. So it's not the first thing to do, but if once we assess you, we might use some of these things to help individuals, but it's not something that everybody should consider. So everybody should consider weight management if it's relevant to them, and therapeutic exercise. That's for everybody. This stuff is for certain people. Okay. In terms of the biomechanics, then this. By the way, this diary, they look like hooves, don't they? You notice. But anyway, in terms of normal, I don't like the word normal, but neutral. So if your legs are just going straight up and down, The weight is going evenly through the inside and the outside. Like Joe was saying, there's medial and lateral compartments. The weight is going through evenly through both. If they're varus, slightly knock-kneed, sometimes that's called, there's more pressure going through the inside of the joint than the outside. And if you're valgus, so your knees are coming in, that's more knock-kneed, apologies, then you've got more pressure on the outside of your knee joint. Okay, so the position of your leg will change which side of your knee is loaded more. And we can help with this through exercise by strengthening up. Often it's around the hips that we strengthen, but by strengthening up, re-educating on movement patterns, that will help to share out the load a little bit. Using insoles and or braces. The braces we've got can help with this as well. Have we got the unloader knee brace? So one of the knee braces we use, thanks Joe, one of the knee braces we use is the Ozza knee brace. And this is effective for the right person. We've got to pick the right people. But if you have this pattern or this pattern, the Ozza knee brace actually supports, the Ozza brace supports to actually reduce the pressure on one side of the knee. And so it makes it feel more comfortable. And if you're suitable for this sort of thing, we can advise you on that. And it can be really, really effective. We used to worry as physios, we used to worry about braces and knee supports and worry that they're going to make the knee weak. But actually, I think it's the opposite can happen. So if you get support, it feels more you feel more confident, and you have some pain relief. You're actually going to use your leg in a better way, so that you get better muscle activation, and so you will actually get stronger and you get fitter and healthier. So, so they do have their places for the right candidate. In terms of medication, it's not high up on the list in terms of evidence-based treatments. Paracetamol is an evidence-based treatment for osteoarthritis. That's a relatively recent change. But the go-to really is the non-steroidal anti-inflammatory gel. So that sort of massage into the knee, you follow the instruction on the packet. That can be really effective. So that can be done as a daily thing, very little side effects, and can be really effective. If that's not doing enough, then you would consider anti-inflammatory tablets, but get advice. So it's outside of our scope of practice to advise on medication. But that's sort of, the medication can help with the overall process, but it's not the answer. All right, so it's part of a package. Okay. Injections. There are various things that you can have injected into your knee. There are certain things that are not within the NICE guidelines. So this hyaluronic injections, there's like a lubricant into the joint. It's not evidence-based, but anecdotally some people have said it's effective. The corticosteroid injection is something that can help just calm things down, but it's very much a short-term answer. So it can help short-term. So the effects of it are relatively short-lived. But if someone's having a real rough time and a real rough flare-up, sometimes it just calms it down to allow them to just move and exercise a little bit more comfortably, and then start to work on some of the longer-term factors as well. Joint replacement. So this is like a cascade. Things are getting a bigger deal, if you like, now. So joint replacement, it's a very effective surgery for knee arthritis, knee osteoarthritis. It is effective, but it is a last resort. So it's not where you go to first. But if someone has a certain condition and there's pain, there's stiffness, that's not responding to therapeutic exercise, and it's still affecting their quality of life significantly, having a knee replacement, or they can do a half a knee replacement, or there are other surgeries as well that you can have. But surgery is a good option for the right person. But what we want to try and do is sort of limit the number of people that are going to ultimately need it. Okay, so we're delaying, we're avoiding, we don't want people to have this, because knee arthritis, and this how much you struggle with knee arthritis, it's not a linear, you're going to get worse just because you're getting older. It can plateau, it can get better, it can improve, and you can have a really good quality of life even though you have knee osteoarthritis. So this stuff isn't inevitable. It getting worse isn't inevitable. Okay. Long term versus short term, then symptom relief is for short term. So you might, if you have a flare up, you may rest for a while. So you may take it easy for a day or two. That's going to help to settle the pain, settle the flare up. You may put heat or ice. It's your choice, if I'm honest. I've spoken before about the difference between the two, and they're actually very similar. So if you have a preference for heat or ice, then putting that on is useful. Taking some painkillers, taking some anti-inflammatories, taking it easy. All right, that's going to help allow the pain to settle down. Not the long-term answer though. If that's all you do, then you're probably going to get worse. So the condition will get worse. So you need to be thinking of improving strength, stability, your overall health, maybe your your weight management. So it's that's the longer term trajectory. This is what's most important. Okay, and so if you get stuck on just thinking about symptom relief, like getting rid of the pain, if you just think about I need to get rid of the pain, if that's all you're thinking of short term, then you won't have such a great outcome than if you're thinking of this when you need to, when you've overdone it a little bit, or you've slept awkward, or you just catch it, you have flare-ups, you want to settle it down. Long term, you want to be thinking about these other things. Okay. Okay. So in summary, I've got the two big things here. So this is for everybody. Should consider those two big things. The other things are the things we've mentioned, and they are sort of more on the edges. And we would assess you. If you see us in clinic, we would assess you, help to advise you on these things, definitely on this one, because exercise, it's not just like everyone get on an exercise bike or whatever. There are some specific exercises for each individual that we would look at. And then the other things are sort of as needed, really, and they're discussions, and it's in the overall package that you want to be considering. Okay. Thank you. Can we stop the recording and then we'll take some questions?